Hello and welcome back to the Crisp TV. I am your host. My name is Dr. Abad Khan. We are interventional cardiologist practicing in St. Joseph Hospital, Ghaziabad, and we are in Mumbai. And today is day 2, and it's absolutely exciting. Sessions are going on continuously, and we have a very exciting guest for us right now, Dr. Zainulabedin Hamdulay. He's a leading cardiac surgeon based in Mumbai, and he's currently the chairman of the Masina Heart Institute in Mumbai. He's currently also the president of Indian Association of Interventional Cardiac Surgeons. Has the experience of working in more than 10 countries around the world. Welcome, sir.
My pleasure. My pleasure.
Sir, as it is a common saying among the our cardiology peers also that keep your patients happy and family happy, but most importantly keep your one cardiac friend, one cardiac surgeon even more happy, because if the push comes to shove, only he can bail out of the situations which may seem irreversible sometimes. What's to say on that, sir?
I think let me start with it's been a privilege to be in this cardiology conference, and I think they are doing a wonderful job. So I was presenting today where surgical bailout for a cardiologist. It's an interesting topic, and I have always been talking that we have now this current generation that we have to work as a team with the new gadgets coming in, with the new era setting in, so much of advances happening that we against them, right? Surgeons and cardiologists, and building a great wall of China in between. So that is not necessary anymore. So a cardiologist, if has to have a good cardiac surgeon as a friend to bail out in difficult situation, and so is this vice versa. A good cardiac surgeon to be successful has to have a good cardiologist behind him to to bail him out in some difficult situation. Now, at the end of the day, it is the patient who is benefiting, and that is what should be our motto. It's not that, I mean, earlier we used to see, I mean, with due respect to my older generation, that that giving up a patient, whether it's from the surgeon side or a cardiologist side, to the other side, was considered, I mean, the ego came in between and considered as a demon. No, you as if you don't know to handle it, and that's why you are asking somebody else. I don't think that is at all necessary, and the newer generation has realized that. So I see now a lot of my cardiologist friends and surgeons friends are mixing together, discussing cases. So the concept of heart team, which was only on paper once upon a time, I think is becoming a reality, because now the interest of cardiac surgeons is there in cardiology procedures, as well as the cardiologists have interest in cardiac surgery procedure, because when you end up in a trouble, you just don't walk away, you are there till the end, how things are happening. So I think now I see over in next few years there will be something called as cardiac physicians, which will be a combination of a cardiologist and a cardiac surgeons who will work together to get the best results out of it.
Absolutely. So, sir is of the opinion we should have mutual respect, and indeed that is the only way where we survive in a world where the outcomes have to be matched to the patient's expectations. Also, we thrive to have results. To have the results best for the patient, sir. So with the advances in cardiology, the new generation stents coming up, rotablation devices, and all those fancy gadgets are coming up. But despite all of that, we are still not able to challenge the LIMA. Why is that, sir?
So let's understand nature. Okay, LIMA is left internal mammary artery, is a God blessed artery. We don't talk about some other artery in the body. This has so much of nitric oxide secreting cells that we hardly see any blockages developing. So it has an advantage, okay, which cannot come through in any artificially made gadget as of today. Okay, stents you may be having, drug eluting stents you may be having, maybe tomorrow genetically regenerated cells. What is important is actively secreting nitric oxide cells into the stents. So that's the vis-a-vis point where it takes away all other things. LIMA to LAD has been a gold standard. Over years, it has proven itself that this is only one indicator of survival. A good LIMA to LAD, a patient will survive. So that's the reason I feel, uh, as of today, because of its years of results which have come out, no one can beat LIMA to LAD.
No one can beat lima duality. That is the interventional cardiologist dream, is that we cannot beat the LED, but at least aspire to be at least as good as the LIMA. So that is what the cardiologist community and the technologies keep pushing for. But unfortunately, LIMA still beats them hands down. Uh, Sir, with the advances in the valve technology also, very strong data now for TAVR has coming up for the now for the even low risk patients, besides the moderate risk and high risk patients now. So, so the rise of TAVR, where do you see the role of mechanical prosthetic valves in India for patients aged more than 70 years, sir?
So let me put you, as of course with the advancing technology, tower is really taking it over. A lot of work which we used to do, replacements have now moved to tower. But having said that, remember it has its own life. Now, if I start putting a wall in a young patient 35 and a tower wall which may not last more than 10 years, we are subjecting to another procedure in 10 years, then another procedure. And it's not that safe to do a tower in tower and tower. So it has its own problems and complication someday. But yes, mechanical valve is a disease in itself. So we are removing one disease and giving a better disease type of a scenario. But with this synthetic valves coming in, that is going to again challenge the tower growing, coming down on age type of it. So if that goes through, then the mechanical valves will be out. Then it will be only long standing. So younger population will start opting for synthetic valves, and with minimal invasive surgery or minimal excess surgery, we can safely put such valves in younger patients which can last longer than tower. So still there is hope. It's not that we are writing it off mechanical valves or surgically implanted valves so soon. Only time will tell. But then as technology is growing in tower, so is growing in implantable valves too. So as I said, this Foldax valve or any other valve which may come up in synthetic form, and if it takes more than 20 years, 30 years, it is going to have an added advantage over tower. So then there is going to be a neck to neck race for survival for the both of this.
Actually, very well placed, sir, and very well put also. Actually, technological advancement is actually the thing and the need of the hour, not only for the cardiologists but of all for the cardiac surgeons also, and that is how we improvise ourselves and improvise our outcome for the patients, and that is how it should be. A healthy, maybe a healthy kind of competition is good for everybody. Also, sir, share some delightful and interesting cases you have had in which you or the cardiac surgeon, that is the one person who really made a difference between a bad complication or an outcome and a life being saved, sir.
So we normally see, I mean, if I say that I have no complications, means either I have not operated at
Yeah,
all or I'm just bluffing and lying about my work. So complication is
happened.
a part and parcel, whether it is a cardiologist, whether it's a cardiac surgeon, and that is how you turn out to be experienced. That's how you have gray hair. There are a lot of situations we come across. So one case I can suggest, tell like here on this forum is, there was one patient while doing tower really collapsed. The valve got displaced, embolized from there. We had already done a balloon, so the patient was literally struggling. And that very moment, as a surgical team was around, so we immediately put this patient on an ECMO. So we call as a CPR ECMO. Okay, all this was happening, we immediately put the patient on pump. So the heart was rested, even if it was struggling, but the load is taken away. So there was no dilatation of the heart and all this. And we immediately shift the patient to OR, and then we operated and we salvaged this patient. So I think these are very adrenaline rushed patients, and the end results, if they are good, I think we have done a great job. Saving a life is, I think, this what is the motto of every physician. That's our Hippocratic oath. So we have to give the best way. So such events we have one patient which had come into our ER with an extensive MI, had arrested there. The CPR was going on for nearly an hour. Credit goes to my ICU registrars that they went on for 1 hour. And then after, when he was going through, he was young chap, 28-year-old, and he was one of the big placed in our corporation. So we put him on again CPR ECMO. We brought him into cath lab. We saw that his whole left main had clot and occluded. So we removed immediately the whole thing, did a PAMI, and and these patients did well. So I think these are certain cases which we work together. Like I mean, the ECMO was put by surgeon, then it was brought to the cath lab. The cardiologist took it over, did the necessary things, and we salvaged the patient. So I think there is where your first question becomes pertinent. Both the cardiac surgeons and cardiologists work together. I think the end result is the patient which goes home with the better results.
Absolutely, this is what we are aiming for, and this is what Dr. Zainul is also saying, that end results is what matters, and it is a team effort. Nobody is a hero, and nobody should try to become a hero. It is a team effort. Both the surgeons and cardiologists are making and trying their best actually to have the best outcome possible for the patients. Um, so someone looking at me also for a middle age or middle career cardiologist, what one advice would you like to give me to have going for my intervention or going to see my patients and doing my interventions, either it's valves or it's PAMI, or maybe it's a stable patient's left limb bifurcations. What advice will you give us for the safety of the patient? What should be done and what should not be done?
So let me tell you, when I started my practice and I came back, I was fortunate basically. I had my bosses who had just retired and who started coming to help me out with the cases. Now, people did say that, oh, does this gentleman know to operate, that why he needs some senior surgeons to help him out? And no, I didn't have anything to tell to people all around. But then one thing I knew, that with their presence there, I have years of experience in that OR. If I am 20 years of experience and my boss has 60 years of experience, there is an 80 years of experience in that OR. Remember that. It's an added thing. You can be cumulative as well. So that's how I would suggest all my junior colleagues or anything. You don't need to shy. If you get some senior who has a much more experience to help you out, then you should ask for help to conduct any difficult cases. Same way for the seniors. If you have so much of knowledge, information, and experience, it's time to share. You don't have to carry it to the grave. I always say that don't carry it to the grave, because that experience, if you impart it to your junior, the results that we are going to give is going to be phenomenal. So when you are working, involve people, take help, and start safely. And the second part of the whole thing is that see that what you give to the people, I mean, you give the best. Think every patient is your father, mother, sister, brother, and that is what treatment what you will give them is what treatment you are going to give to that patient. For me, as a surgeon, every patient under the drapes, once the patient is draped, you don't see the face. A surgeon never sees. He just sees the heart and his chest. I don't know whom I'm operating. So think that today you are operating on your father. Today you think you are operating on your brother. So how you will do? That same zeal, same interest, same effort has to be given to every patient. What is best for him is best for you, will be best for the other, whatever patient you are operating on. The same way, when we take a decision, what is best in interest of the patient is the decision that we should take. It's not that because I'm a interventional cardiologist, so I am going to do anything and everything. I don't have to send a patient. We used to hear this. I never send a patient to a surgeon, ever think. But that's not the way. Or a surgeon saying the other way around. My patients don't fail at all. No, it's not say that. If the patients, like I mean, we have developed a hybrid procedure. If I am doing a minimal invasive and I find that it's difficult to reach the thing, I'm not going to tax my patient and make things difficult. I will send them down to the cath lab and do a stenting of the right. So involving a cardiologist, cardiac surgeons into it becomes safe outcome.
Absolutely. This is sir has been saying throughout the talk and throughout the podcast that do not, please keep your egos aside. That is what he's trying to say basically. There's no need for any selfishness or ego to be present in this field, and it's absolutely necessary to have an empathy actually for the patients to achieve the best outcomes, and that is how you grow and you become a better person also, and a better surgeon or a better cardiologist. Sir, how do you find this conference, this CRISP 2025, from a surgeon's perspective?
I think I'm impressed. So, for the first time, there was a fair number of cardiac surgeons in any cardiology conference. I think a lot of cardiac surgeons, my junior colleagues, who got a chance to speak, and their work, what they presented, was appreciated by the cardiologists. And that is exactly what I tell my junior colleagues also, that speak in all possible forums, because till you don't speak and show your work, the other side will never know. Like in one of the morning session, when my junior colleague showed all his aortic work, the cardiologist said, one of the senior cardiologists, I don't know such type of work is going around in Mumbai. I'm impressed. I'm thoroughly, I mean, that's what it is. So we have to showcase our work. We have to mix together. And then I'm thankful that the organizer of Chris have given us opportunity to come over and we talk. And I think we just did not feel out of place here. So all my best wishes to this. And I think it's a great, successful, beautifully organized conference. Hats off to everybody.
Thank you so much, sir. And this is how we learn and we become better. And that's all from this podcast. See you in the next one. Bye.
Thank you.